Hi, everyone. How's it going? All right, so not much changing in payment, so this will be quick. All right, so I would like to try and settle a debate. And I apologize to everyone on the line that they're not going to get to answer this question, though they can answer it for themselves. But just a quick sort of straw poll in the room. How many of you consider your Med-A beneficiaries patients? How many of you call them residents? Wow, that's actually not settling the debate at all. That's really split. All right, how many of you see them as people whose care needs should be driving their care provision and not service utilization? Great. If you don't have your hand raised, put your provider number in Slido. We'll talk to you. All right, so we're going to be talking about the patient-driven payment model, a series of objectives in terms of things that we'll go through. According to this clock, I have 13 minutes left in my presentation, so this is going to be quick. So, disclaimer language. There's some acronyms. We like our acronyms at CMS. So, first thing we're going to do is just kind of do an overview of sort of where we are relative to payment and sort of how we got here. So the first thing is, in order to understand why we're here with PDPM, we have to understand where we've been and sort of what the issues were that brought us to this point. The first thing I think is not surprising to anyone is that there are a number of issues with the existing system with RUG-4. These issues have been identified by our own data, by your data, by MedPAC, by OAG, by many other people, by in the media in fact. And there are two main issues that we can talk about as far as RUG-4. The first, and I think the most obvious of which, is that currently therapy payments are driving the system, are driving care provision. That we see things like, I need to get to 720 minutes worth of therapy. I need to get to 500 minutes worth of therapy. And those of you who've seen me talk before, especially recently, have heard all of this kind of stuff before. But when you look at therapy distributions and you see between 0 to like 350-ish minutes, it's sort of a normal distribution, people receiving some amount of therapy. And then when you get to around 500 minutes worth of therapy, there's this giant spike in the distribution between 500 and like 510. And then it drops off precipitously into like almost nothing. And then you get to about 720, and then there's this giant spike again, and it goes up again. And there's, again, between 720 and 730 minutes of therapy. And it's always been interesting to me that so many people, so many Medicare beneficiaries benefit from exactly 720 minutes worth of therapy. Not more. 740 would be awful for these people, and 710 is terrible, but 720 seems to be the sweet spot for everyone. And we all know why. We all know the way in which the existing system is incentivizing and driving care provision in that way. Now, the second issue is one that is I think, less thought about, but I think is equally important, and that's that we have people that are in the SNF that have various different types of needs, various different types of goals, and all of them are falling into the same basic groups. They're falling into RU and they're falling into RV. And so despite very significant differences between the kinds of care needs and goals that these people have, they all end up in the same groups. And that seems wrong. It seems wrong that we would be only using a few groups to identify and describe all these different varied patients. So we enter PDPM, the patient-driven payment model. And we believe that this represents a pretty marked improvement over the existing system in a variety of ways. The first is that it improves payment accuracy and appropriateness by focusing on the patient and their needs rather than just on the services that were provided. It significantly reduces administrative burden for everyone, I think. We'll see. I mean, I've heard from some people here that really like the existing assessment schedule, so we can keep it if you want, but I think the new one's better. And it also reallocates SNF payments. And there was a question that had come in over Slido that talked about sort of the potential budgetary impact of PDPM. And one of the things I wanted to note is that we are implementing this in a budget neutral manner. That is that we're not intending for PDPM to change the overarching bucket of SNF payment. So I think it's an approximately $36 billion baseline each year. That $36 billion, that massive bucket of money, that stays the same, regardless of the payment system. It's not intended to change that. What it is intended to change is the way in which we allocate that money. So currently, about 93% of days are paid for using a therapy group. We want to see that change. And one of the ways that PDPM will change this is by it shifts that $36 billion around and moves it more toward the medically complex patients that are having trouble getting into the facility and less toward those just high rehab patients. Now we'll talk about how it's going to do this. And the first thing, again, to start with is to understand the current system. So we have RUG-4, which consists of two case mix adjusted components. There's a therapy component that is entirely driven or mostly driven by the volume of services provided. There's also the functional status. And again, those of you who've heard me talk before have heard me say this, that it's always struck me as odd also that for any facility that I walk into, and I've had the benefit of walking into a number of different facilities around the country, especially when I go to do talks like this. And in any facility, it seems odd to me that I can walk up to a Medicare beneficiary and without knowing anything about them, all I really need to know is two things, or two questions. I have to say, what is their general functional status? And how much therapy did you get last week? And based on those two questions alone, I know what we're paying for 93% of the days that we pay for under Part A. And that just seems wrong. It seems wrong that I know that about a person without knowing anything else about them. On the nursing side, the nursing component does actually do a good job of reflecting changes and variations in nursing costs, which is why the nursing component under PDPM is generally the same as that under RUG-4. The problem with the existing nursing component, though, is that you never actually see it. Right now, the nursing component of the RUG-4 rate is driven by therapy. You get a nursing case mix weight based on how much therapy they got. And so despite wide differences between different types of patients, they get the exact same nursing rate. And I think we can all agree that nursing costs are not the same depending on which patient you have. The other thing about RUG-4 is that, and there are some things that we just couldn't change about the SNF PPS, and one of them is that it is a per diem system. Okay, that is in the statute, talk to Congress. So it's a per diem system, that is you get a payment rate per day for each day that person's in the stay. And RUG-4 uses a constant per diem rate. So whether it be day 1 or 100, you get the same per diem rate. And one of the things that we saw in our data as we were doing the analysis was that that's not how costs are incurred. Okay? It's not just the person comes in on day 1, and if they stay until day 100, they cost exactly the same amount the entire time. We saw that that cost varies over time. And so to try and address that cost variation, we introduced a new element, which we'll get to in just a moment. This is a depiction of what the current system looks like. It looks relatively simple. I think we could all agree that it maybe oversimplified in terms of its effect on therapy. And then we moved to PDPM. That does have more components. And so I've heard a lot over the past year about the complexities around PDPM. And we'll get to a depiction of PDPM in just a moment that will look more complex. But really all we've done with PDPM is take those two case mix components, therapy and nursing, and we just broke them out into their constituent components. So therapy gets broken out into its 3 disciplines, PT, OT, and speech, and we're able to adjust for each of them. And then nursing gets broken out into its 2 constituent components, which are nursing and NTA. And for long as I say NTA or non-therapy ancillary, just think drugs, because drug costs are the main cost driver behind NTAs. So right now, NTAs are folded in to the nursing component. And so while the existing nursing component does a very good job of identifying variations in terms of nursing cost, it doesn't do a great job in terms of identifying variations in NTA costs, which is why we felt it was important to try and split that out. The other thing about PDPM is that it includes a variable per diem adjustment. Okay, so what that means is that it's going to adjust the per diem payment over the course of the stay for 3 of the components, for the PT, OT, and NTA components. And for PT and OT, it does it in sort of a more gradual way, where the payment stays at a constant rate for the first 20 days and then begins to drop every 7 days thereafter. The NTA is markedly different than that, though. And that's because that when we were doing our analysis and when we were doing our technical expert panels, which some of you have actually served on, which was, again, all of this is based on stakeholder input. When we were talking about NTAs, one of the things that we realized is that you don't incur NTA costs in the same way you incur other types of costs. So with a therapy cost, it tends to be, again, the same and it sort of trails off as the stay goes on. Nursing, stays relatively the same. SLP, we actually found, stays relatively the same. NTAs, though, when it comes to drug costs, if you go to Walgreens or CVS, I'm not picking one. If you go to one of those pharmacies and you go to get drugs, you don't go each day buy that day's drug, and then come back the next day and buy the next day's drug. You buy a 30-day supply, a 60-day supply, a 90-day supply, and then dispense it to yourself, okay, or in a facility it's dispensed to the patient over the course of time. Now, if someone comes into the building with an expensive drug, and you incur the cost of that 30, 60-day, 90-day supply, and then that person discharges a week later, you have a lot of money that you're left holding that you're not being reimbursed for. So what we did with the NTA component was basically front load that drug cost so that people who have those high drug costs will be able to get into the building and that the facility won't have to worry that if the person discharges, they're going to be left without getting properly reimbursed for those medications. This is what PDPM looks like. Again, it looks slightly more complicated in the sense that there are more boxes, but they all follow a very similar format, which is you have a base rate. The base rates are the same. They're actually based on cost reports from 1995, which was lots of fun for our contractor to find. There's a CMI. The CMI, or case mix index, just reflects the relative cost of a person in terms of it being more or less costly than an average. And then the VPD, or variable per diem adjustment factor, that's applied to 3 of the components. There's the non-case mix base rate. It's exactly the same as the current one. And then for nursing, there's a slightly nuanced aspect, which is the 18% add-on for patients with HIV and AIDS. We have the existing add-on under the current system of 128%. What we found is that we were actually paying more money for people who had higher therapy needs, which is actually the exact opposite of what the data showed in terms of the effect of therapy on people with HIV and AIDS. It was actually higher for nursing rather than for therapy. So we've changed how the add-on for HIV and AIDS is done so that there is points that you get on the NTA component. Okay, it's actually the highest one that you can get. And then there's an 18% add-on for nursing. Add up all those components, and you get your PDPM per diem rate. And this is one of the key things that differentiates PDPM from the existing system, is that the current system takes everything about a person, takes all of those nursing needs, the NTA needs, okay, all of the various needs that a person has, and boils them down to a single RUG-4 group. Okay, and as I've mentioned before, it's typically a group that starts with the letters RU or RV. Okay, I think RU currently represents something like 62%, 63% of all days. RV is like 20, 25%. So I mean, we're talking about a major portion of days that just goes to those 2 groups. And everything about a person gets boiled down to that single group. PDPM that's depicted on the other side, though, tries to look at each of those needs independently and adjust for them independently. And it is able to provide a much more nuanced and accurate payment for a specific patient. Now, we have heard that the number of HIPS codes that can be produced as a result of this system is rather gargantuan. I think it was 26,000, something around there, potential combinations. And the reason that doesn't worry me too much is because, number one, your software will be doing most of that calculation for you, although we'll be doing a case study in a little bit today, so we'll be producing a HIPS code ourselves. But the other thing is that right now, about 6 codes are being used for the vast majority of patients. Okay, RU, A, B, and C, and then RV, A, B, and C. And I think that there are more than just 6 types of patients. Okay, are there 28,000 types of patients? Maybe not. Maybe there's only 12,000 types of patients. But the PDPM HIPS codes will actually allow us to see those kinds of variations between different types of patients that we're not seeing under RUG-4. The effect of this that we've talked about is being able to, again, see those sort of nuanced differences. So if a patient has a higher NTA needs or higher SLP needs than another, whereas the other patient might have higher PT and nursing needs, the current system that would put them both into the same bucket, PDPM is able to differentiate between those patients and pay for them more accurately and in a more nuanced manner. So we're going to go through just a sort of a quick example of how someone is categorized under RUG-4 versus how they're categorized under PDPM. And we have these 2 patients. Okay, patient A and patient B, because we're very clever in our naming. So patient A, okay, they have a variety of different characteristics that you can see there. Patient B, very similar. You'll notice, though, that the first 4 characteristics for these 2 patients are exactly the same. You'll notice that they're both receiving 730 minutes worth of therapy. Okay, so that's actually high in that range. Same functional score, okay, no extensive services. And for those 2 patients, and for 93% of the days that we pay for, those 4 things are all I need to know. Okay, again, that seems wrong. Go below that, start at clinical category and run down. Those are the characteristics that we need to know for PDPM, okay? And each one of them has things that get baked into them that makes, again, for a much more accurate and nuanced payment. So RUG-4, based on those 4 characteristics, okay, that they received rehabilitation, they didn't have extensive services, they were above 720, and they had a functional score, okay, of 10, that puts them into RUB. Okay, again, it is very simple, but it doesn't provide for a very nuanced or accurate payment for different types of patients. So now we see what PDPM does. And for the first two components, okay, PT and OT, we see those two aspects of the classification. The first being the clinical category. The clinical category is based on the question, okay, which is, I think, is a pretty important question to ask ourselves. What is the main reason that person is in your building? Okay, and we've gotten a lot of questions about this from folks over the past year. People saying, well, what am I supposed to put as the code for this? How am I supposed to know what to code in I-20B? And my answer is always the same, which is, what is the main reason they're there? Okay, not what is the main reason they were in the hospital. Okay, that is a distinct question. Okay, because the reason that they're in your SNF could be distinct from why they were in the hospital. Okay, it could have been for something that arose while they were in the hospital. Okay, an acute infection or something like that. So what is the main reason you brought them into your building? That's all the clinical category is really there to identify. Okay, and we have 4 different options. There's actually 10 clinical categories, and then those consolidate into those 4 for the PT and OT component. So patient A, who's depicted on the left, had an acute neurologic condition and a functional score of 10. So you can see that they go into the non-orthopedic surgery, not acute neurologic group, and then the 10 to 23 functional score bin. Patient or resident B, who's depicted on the right, had a major joint replacement spinal surgery group and a functional score of 10. Again, already you can see that under PDPM you're getting a different classification for these two patients as compared to RUG-4. The SLP component uses very different criteria than the PT and OT components. I will say, we actually tried very hard to identify characteristics that would have allowed us to separate out PT and OT, and we just couldn't find any. The data just didn't suggest any that were statistically significant. SLP, however, was very distinct in terms of what drove SLP classification. So here, the first one being that if there's the presence of an acute neurologic condition, an SLP-related comorbidity, or a cognitive impairment, gets you into that first group of classification. And the second being whether or not they're on a mechanically altered diet or if there's a presence of a swallowing disorder. So patient A, who's depicted on the left, had an acute neurologic condition, moderate cognitive impairment, and is on a mechanically altered diet. And so they get the NE2 for the first bucket and then either for the second. Patient B, depicted on the right, didn't have any SLP-related issues, and so they go into the none and neither category. Again, showing the difference between how someone is classified under PDPM versus RUG-4. The NTA component is driven by what we refer to as an NTA comorbidity score. We actually looked at various ways that we could have done the NTA comorbidity score. One way that we thought about was to just take the highest point condition that a person had, the most acute condition that the person had. And while that worked, what we found is that it didn't account for the fact that if someone had multiple comorbidities, that they ended up costing more. The other way was to consider just a sheer count of comorbidities, to again account for that fact that more comorbidities tends to cost more. And that, again, works for part of it, but fails to address the fact that there are certain comorbidities that cost more than others. So what we did was basically create a tier system or a ranking system where we ranked each of the conditions based on a relative number of points. You code the conditions that person has, add the number of points that person has for their NTA comorbidity score, you get a total score, and then they fit into one of these buckets. So patient A on the left had IV medications with a score of 5, and diabetes with a score of 2, and they have a total score of 7, which puts them into the 6 to 8 bucket. Patient B, depicted on the right, only had chronic pancreatitis. I say only, that's still bad. They have a score of 1, they're in the 1 to 2 bucket. Now, as I mentioned, nursing is pretty much the same as it is currently. Okay, we've collapsed some of the groups together. We're using section GG as the basis for our functional assessment as opposed to section G. You're welcome. And I think, or if you don't like it, then I'm sorry. So patient A, receiving dialysis services with a nursing function score of 7, okay, they go into the group LBC1. Okay, whereas patient B had septicemia, also a nursing function score of 7, and was exhibiting signs of depression, and therefore is put into group HBC2. So again, for each one of those components, whereas RUG-4 would have put them into exactly the same group, PDPM is able to actually account for them each in a separate manner, in a much more accurate manner. Now, we're going to talk about 2 sort of overarching themes throughout today. The first is going to be what PDPM changes, because as I'm sure you've realized over the course of these last couple days, as I'm sure you've realized over the course of the last year, there's a lot changing under the SNF PPS as a result of PDPM. Okay, I try not to toot my own horn very much, but saying that this is the most significant change since the inception of the SNF PPS, I don't think is inaccurate. Okay, this is a major change, and what I've been hearing from folks is that for the most part, a pretty welcomed one, okay? That being able to actually isolate these differences between patients, being able to bring the nurses back into the fold, being able to have therapists exercise their clinical judgment about whether or not that person does need 20 more minutes of therapy as opposed to just hearing an artificial threshold, that this is a major change. And understanding all of these various changes that we've been talking about throughout this conference, okay, and that we're going to continue to talk about throughout today, is very important to being able to succeed under this new program. So the first main area of change is in terms of the data that we use for patient classification. So as I mentioned, I don't really need to know much about patients currently to know what group we're going to classify them into for payment purposes. Okay, I really need to know just, again, those two things. How much therapy did they get, and what is their functional status? And those tell us very little about the actual patient. Okay, I've actually heard from a number of people that, in terms of getting to that 720, it doesn't really matter much about the person. Okay, one of the things that I hear often, and I will tell you right now that it irks me, is whenever I hear someone refer to a patient as an RU patient. They said, well, if I have this RU patient, and I'm like, no, you don't. You have Mrs. Smith, who is a person that has conditions and comorbidities and goals and needs. That's who you have. You don't have an RU patient. RU is a service-based utilization measure that says how much therapy did that person happen to get over the past week. Okay, so it tells us very little about the patient that they're in RU or in RV. PDPM will tell us a lot more about the patient, just from the assessment, just from knowing what that the HIPS code is. I know a lot more about that patient. Okay, I'll know generally what their primary diagnosis is. I might not know the specific code, okay, but I'll have to know the specific code if I'm going to know what clinical category they go into, and then what PT and OT and SLP category they go into. I'll know more about their comorbidities. I'll know more about their functional status, about their swallowing and nutrition needs, and so many more other characteristics that just are simply not relevant to payment under the current system. The other big change, again, is the variable per diem adjustment. Okay, so as I mentioned before, okay, it's a per diem system. The current system has it where you have just a constant per diem rate, allocates to you for your resources at the outset of the stay, and so to improve the accuracy of the system, we introduced the variable per diem adjustment. And here you can see the two schedules that we use for the PT and OT component. Okay, again, starts for high for the first 20 days, and then starts at sort of a 1.0 adjustment factor for the first 20 days, and then goes down by 2% every 7 days. Okay, so it's a pretty nice stepping process. NTA, front loaded for the first 3 days, you get 3 times the per diem rate, and then it goes to more of a regular rate for days 4 through 100. The emphasis of care changes significantly under PDPM, whereas currently, again, this is one of the other things that sort of irk me a lot, is whenever I hear people referred to as a therapy patient versus a non-therapy patient. Because for years, I've been hearing about the increased acuity of SNF patients, that they're coming to your building sicker and quicker, and that people have a wide variety of needs than just one. Okay, they're not a therapy person or a non-therapy person. They're both. They're a person that has therapy and non-therapy needs alike. So whereas the current system incentivizes, okay, and puts right up there this dichotomy between therapy and non-therapy patients, PDPM eliminates that dichotomy and says everyone is a therapy patient, everyone's a non-therapy patient. Everyone has distinct needs. Everyone's going to get classified for every one of those groups. Okay, and so it raises the level of complexity of the system, but it also raises the level of importance of every single one of those disciplines and brings them all back into an IDT meeting to all equally share about the needs of that given patient. Payment for HIV and AIDS, again, as I mentioned earlier, is very different. The current system, again, uses a 128% adjustment for the full per diem. And so what that ultimately means under the current system is that if you had someone in RV and then you gave them more therapy and they went into RU, that 128% now has a larger impact. Okay, but what we found in our data was that that having HIV and AIDS was actually negatively correlated with increases in therapy cost. Okay, it was more connected with increases in NTA and nursing costs. So to try and address that better, we have eliminated the 128% adjustment and instead have a much more tailored adjustment that focuses only on the nursing and the NTA component. So again, for NTA, you get that 8-point increase, okay, the highest increase you can get, and for nursing, you get an 18% add-on. Important thing to note, okay, that's noted on this slide, is that the way that it's reported currently, okay, that you report the B20 code on the claim is exactly the same way that you report it under the new system. Okay, again, the impact is different. The way that the pricer is going to effectuate that change or take account of that change is very different, but the way that it's reported from an administrative point of view is exactly the same. Some other areas that we talk about as far as PDPM-related changes, okay, and there are 4 key areas we're going to focus on. The first are MDS-related changes. Now, Terry's already done an amazing job of talking about all of this. I'm going to just kind of briefly go through a number of these. Now, one of the biggest complaints that I've heard from folks about the current system is about the assessment schedule, okay, that we get questions like, so John, if I have a person who had a 14-day assessment and I have the ARD set for this, but then they have a COT that's also due on day 13, but do I do the 14-day and then I offset the COT, or do I do the COT, but wait, now they ended therapy, so do I do an EOT combined with the COT? Whoever's doing that, by the way, good luck keeping up with this. It's insane, okay? It is ridiculous to try to keep up with all of those assessments and try to keep up with all. MDS nurses have one of the hardest jobs in these facilities, trying to keep up with just the range of assessments that have to be combined or separated, and it's a lot. PDPM has a much more simplified and streamlined assessment schedule, okay? It's really just 3 assessments, and we're going to see what those are in just a moment. PDPM also uses section GG that better aligns us with some of the other payment sectors. And that's one of the other underpinnings of PDPM, is that as opposed to the RUG-4 system that I think is categorically different than where many of the other systems are going to. You've seen the patient-driven groupings model that's coming for home health. If you're familiar with the IRF PPS in terms of how that's been paying, RUG-4 has been categorically different than all of those. Okay? And so PDPM helps us to better align us with those other systems, okay? Which is something that the Impact Act is trying to get us to do, and something that PAC reform is also trying to get us to do. So the current RUG-4 schedule is this. Looks fine. Okay, you have a start of therapy OMR, an end of therapy OMR, a change of therapy OMR, a significant change in status assessment, 5, 14, 30, 60, 90-day assessments. It's a lot. And then combinations of those assessments. If you miss one of those assessments, it's provider liable. If you get the ARD wrong for any of those assessments, you have default payments. Okay, there's a lot of potential provider risk associated with the complexity of that schedule, and it has nothing to do with the patient. It has to do with administrative burden. Okay, and that's not what you should be focused on. PDPM has 3 assessments. The first one, the 5-day assessment. It's the exact same assessment you're doing now. There's a few changes in items, things like that Terry talked about, but it's generally the same assessment. ARD, basically the same. It's days 1 through 8. Okay, payment impact, it covers the entire Part A stay. Okay, that's it. That's all you have to do. If you just want to do a 5-day and be done for the day, you're done. Okay, that's all you have to do. The IPA, the interim payment assessment. I'm going to say this, I'm going to say it again, I'm going to keep saying it. It's an optional assessment. John, do I have to do an IPA when I do a significant change? You can, but it's an optional assessment. John, when am I going to get cited for not doing an IPA? You won't. It's an optional assessment. It is entirely at the discretion of the provider. Now, I have heard from some providers that they are coming up with various criteria to identify for their facilities when, and for their clinicians, when an IPA should be done. That's fine. You can go do that. I am not telling you to do that, nor is CMS, okay? It is an optional assessment. You will never see us come down on you and say, you should have done an IPA here. Okay, it is an optional assessment. Now, if you do that optional assessment, and one other question that we've gotten a lot has been, can I do multiple IPAs? Sure, that's part of the option. You can do multiple IPAs. Okay, if you really like the current system with doing a COT every week and you want to do an IPA every week, have fun. You don't have to though. It is an optional assessment. Now the payment impact of that optional assessment is that it pays from the ARD of the assessment through the Part A discharge unless you do another IPA, which again is optional. I was going to do a Slido on is it optional, and I felt like that was too much. The third assessment is the PPS discharge assessment. Again, exactly the same assessment you're doing now. Some new items, okay, to track therapy utilization. Okay, we think that's important because we have heard the rumors about what could happen to therapy under PDPM. I'm sure all of you have heard them as well. But other than that, it's the exact same assessment. Okay, it's the same PPS discharge assessment. It's optional. Again, I don't know how many times I can do this. It's an optional assessment. Okay, the other assessment that's new under the current or new under PDPM is the optional state assessment. This was done to aid Medicaid programs that are currently using legacy payment models to support their Medicaid programs. And so the OSA, or the optional state assessment, which is also optional, is the assessment that states would be able to use to continue to work under legacy programs. We'll talk a little bit more about that later. Limits on concurrent and group therapy. Now, there is currently a limit on group therapy. And you might be asking, okay, why is it that, why did you make a change here? So, and Terry has already spoken about what concurrent and group therapy mean. Again, under the current system, there is a 25% limit on group therapy. The definitions are here, that you have concurrent therapy as one therapist with 2 patients doing different activities, group therapy being one therapist with 4 patients doing the same or similar activities for now. If you've read the proposed rule, make sure you comment. So, under the current system, RUG 4 has a limit of 25% on group therapy. One of the things that we saw coming out of the gate was that if you move to a system that is much more prospective in nature, which PDPM is, certainly as compared to RUG 4, and what we're doing is we're basically paying for the therapy up front. We're saying, based on various characteristics, we believe that this person will cost X in terms of their therapy. Now you go, therapists, and dictate what is the most appropriate way of providing therapy. Okay, what is the most appropriate amount of therapy to provide? No longer thresholds, none of that. Okay, we're trying to empower therapists to actually exercise their clinical judgment about how much and what type of therapy a person should be receiving. That being said, we've seen what has happened in the current model, okay, when these types of incentives can exist. There was a meeting that we took with, I'm just going to say, a group. And the question was posed to one of the representatives from that group of, if we were to limit group therapy to 25%, how much group therapy would you provide to your patients? And without a moment's hesitation, what do you think they said? 25%. Then we asked, okay, if we were to put that limit at 50% for concurrent and group therapy, okay, how much group therapy would you provide? And what do you think they said? No, they actually said as much as the patient needs. No, they didn't. We were hoping they'd say that, and they didn't. They said 50% without a moment's hesitation. Now, that's a pretty bold admission, okay, to CMS, that we will provide 50% group therapy if we can to our patients. There was no mention of the patient. There was no mention of patient need. There was a mention of, if you allow us to do 50%, we will do 50%. Given that, that is why we felt it was important to put a limit on concurrent and group therapy. And the way that we've done that is with those discharge items, okay, that Terry had mentioned in section 00425. So providers will report in 0425 the amount of concurrent and group therapy that a person received. Those minutes will then be used to calculate compliance with this 25% limit. This is how that calculation will be done. So you'll have the total number of therapy minutes by discipline, captured as is the sum of all of the individual, group, and concurrent. We will then take, in step 2, the total concurrent and group minutes, okay, by discipline. That is an important thing to mention, is that this is a per discipline limit. It is not a full limit. You can't, skimp a little on SLP to get more group therapy on PT. Okay, it's a per discipline limit. In step 3, we see the concurrent and group ratio. Okay, that is just the ratio between the total minutes versus the concurrent and group minutes. And if that ratio is greater than 0.25 or 25%, then it is deemed non-compliant. Okay, an example of that, okay, we have a total number of PT minutes of 2,000, concurrent minutes of 600, and group minutes of 1,000. And the question is, does this comply with the concurrent and group therapy limit? And so we walk through those steps. The first one being that you add all of the minutes together, and you get 3,600. Then you look at what is just the total number of concurrent and group minutes for this discipline, which is PT, and you get 1,600. And then you do the ratio. What is the total ratio of concurrent and group minutes to total minutes? And you get 0.44 or 44%. That's greater than 25%. So this would be deemed non-compliant. Okay, relatively simple. Example 2 walks through the same thing for SLP minutes. Again, you add them together, you get the total minutes. You add the concurrent and group minutes, you then do a ratio between them. In this case, it's a 20% ratio, so that is deemed to be compliant. The impact of that, something that I hadn't mentioned, is that if it's found to be non-compliant, then what happens is that there's a warning message on your final validation report. I'm just going to tell you now, we'll be watching to see how often that warning pops up. Okay, so if we see that warning popping up a lot, and if we see it popping up for all of your patients, that's going to trigger something. The next change is interrupted stay. Okay, again, Terry's been talking about it. We've talked about it a number of times throughout this conference. It's a very new thing for the SNF PPS. Okay, but the reasons that it exists are, again, the same kinds of reasons that we're moving toward PDPM. So under RUG 4, if a patient leaves the building, if they discharge from the building, and then they come back, you do a new 5-day. Okay, it's much more simple, okay, than where we are going. However, what we don't have under RUG 4 is the variable per diem adjustment. So again, thinking about incentives, okay, and thinking about trying to counterbalance incentives. The variable per diem schedule has a very high rate for the NTA component, okay, it has 3 times for that per diem rate. An unscrupulous facility, perhaps, a malevolent facility, might choose to have a person come into the building, stay for 3 days, go home on, say, a Medicare-required holiday, and come back a couple days later for another 3-day stay, re-upping that high NTA payment. That's the scenario that we were foreseeing. And that's exactly the scenario that we foresee in the IRF PPS, as far as why they have an interrupted stay policy, and why one exists in the IPPS as well. So we've seen this type of incentive in other systems, and we've learned from that, and we see why the interrupted stay matters. And so that's why we've introduced the interrupted stay policy into the SNF PPS. Terry's already done an amazing job of going over the interrupted stay policy, so I'm not going to spend too much time going through it. But as she had mentioned earlier, if a person is discharged from a SNF and readmitted to the same SNF no later than 11:59 of the 3rd consecutive calendar day after having left Part A coverage for any reason, okay, that is, if they left because they were discharged to the hospital, they went home, they went to a different SNF, they went to an IRF or home health, wherever they went, if they come back to the same SNF within that interruption window, it's an interrupted stay. Now the impact of that is twofold. The first is that the assessment schedule continues from the point prior to discharge. Okay, so no new 5-day, okay, you just go on from where you were in the assessment schedule. You can do an IPA, but it is, thank you. The second is a variable per diem, okay, the variable per diem schedule continues from the point prior to discharge. Again, that's pretty obvious given what I was just talking about in terms of the incentives, okay, and why we introduced this policy. Here, again, if they were discharged from the SNF and readmitted outside of the window, if they were admitted to a different SNF, if they came back, for either of those 2 reasons, again, if they were outside of the window or to a different place, then it's a new stay. If it's a new stay, it re-ups the assessment schedule, re-ups the variable per diem. Examples that are here, Terry just went through a number of examples of the interrupted stay, so I'm not going to really spend any time on this, but if anyone has questions about it, certainly those can come up. A lot of examples on interrupted stay. Now, the HIPS coding, which has generated some questions because we made a mistake. The HIPS code, this is the right one. Anyone who asked, okay, it's different between these 2 sources that are here today, which one's right? That's the one that's right. Okay, you have the current HIPS code is 3-character RUG code and a 2-character AI. The new one, okay, the new HIPS code for PDPM is also 5 characters. Okay, but each of the characters represents something different than the current system. The first character is the PT and OT payment group. Second character is SLP. Third character is nursing. We apologize. Character 4 is NTA, and the 5th character is that same type of AI code. Okay, tell us what kind of assessment generated that code. Default billing still exists under PDPM. We expect it'll be a lot less frequent, but it does exist under PDPM. As under RUG 4, you would bill default in cases where an assessment would be considered late. And that's really the only time that you'd be billing default. There are some other potential instances, such as when a stay is less than 8 days and things like that are outlined in Chapter 6. But for the most part, default billing tends to happen when an ARD is outside the window. Now, the default code under the current system is the AAA00. The default code under PDPM is the ZZZZZ, because really you have to be asleep at the wheel to get the default code under PDPM. The only real time it's going to happen is if you have a late assessment. There's no early assessments. You can't have an early assessment under PDPM because you can't have an early 5-day, and the IPA can't be early. It's optional. And you can't have an early PPS discharge. It's at the end of the stay. Okay, so and it also doesn't affect payment. So you can't have an early 5-day, so you can only have a late 5-day. It's one assessment. Get it done. Get the ARD set by day 8, and you're fine. Okay, so don't be billing default for that reason. But the default rate, as under the current system, represents the lowest per diem rate. So if you look at the lowest rate under each of the components, sum them together, that's your default rate under PDPM. Medical review and data monitoring is significantly different under PDPM as compared to RUG 4. And the reasons for that should be pretty obvious. And that is that under the current system, the main thing that we focus on is therapy. Okay, 93% of days are paid for using a therapy group. So we're not going to focus too much on the nursing side. Okay, we're going to focus on the therapy. We're going to focus our integrity efforts and resources on where the money is, which is in therapy. Under the new system, okay, PDPM, because it takes a much more holistic approach to care, it also takes a much more holistic approach in terms of data monitoring and program integrity. So for program integrity, it also means that your provider risk is a lot more easily mitigated in the sense that we focus much more on specific characteristics that are easily documented in a medical record rather than questions like, should that person have gotten 730 minutes of therapy or 710? That's a much harder question to answer. Okay? I'm not saying we can't answer it, and I'm not saying that it's not a problem when all of a facility's patients are getting exactly 725 minutes worth of therapy. That makes that question really easy to answer. But it doesn't, again, it doesn't take account of the holistic style of PDPM. And so for PDPM, we're going to be looking at a lot of other things, okay, that again are much easier for a provider to ensure are well documented. Okay, if you put a major joint replacement, okay, if you code major joint replacement and get them into that clinical category, I should be able to find major joint replacement in their medical record. That's a pretty easy one. Okay, if they had a hip replacement in the hospital, you code it, and that's why they got that's why they're coded into a hip replacement under the SNF. If they have diabetes, okay, if you're checking off diabetes on the assessment, I should be able to find it in the medical record. It's a much more specific thing that the reviewers are looking for, and makes it much more easy for you guys and not have to worry so much about things like therapy minutes. Now, that being said, therapy services are still an extraordinarily important aspect of care under PDPM. Okay, this is another thing that I've heard that irks me a great deal, is when I hear about facilities talking about either laying off therapists or about the fact that therapy is not as important under PDPM. That could not be further from the truth. Okay, therapy is very important under PDPM in the same way that nursing is extraordinarily important today and has been since the inception of the CIF PPS and beyond, okay, since the first opening of a nursing home. Okay, nurses are extraordinarily important even if the payment system is not reflecting that. Okay, PDPM reflects that in a much better way, but it is not meant to take away anything from the therapists. Okay, so therapy services will still be something that we look at. In particular, one of the things we'll be looking at is what happens to therapy services. We'll talk more about this in just a few minutes, but this is going to be an important aspect of our monitoring. And this is not something that, when I've spoken to folks, that we're being too secretive about. We're not, keeping our monitoring strategy hidden from you. We're telling you right now, this is what we're going to be looking at, and it's going to be a lot. Okay, we're going to be looking at how much therapy is that person getting? How were you providing that therapy before? How are you providing it now? Okay, what types of diagnoses did they have before that you were coding before, and what types of diagnoses are you coding now? All of those things we're going to be looking at. Okay, the other important thing we'll be looking at is quality outcomes. Okay, and again, that can't be stressed too much, is that we're also going to be looking at what happens to a facility's outcomes as a result of any changes that we see in any of the other monitoring data. If we see that therapy services are coming down because, or that group therapy is going up because you're experimenting with different models of care, but that we see that quality outcomes are being maintained, that is fine. Okay, that means a lot less to me than a facility that I see that has dropped their therapy down to say like 30 minutes or 100 minutes of therapy for every patient every week, and their quality outcomes are going into the tank. That's the facility that's going to draw our ire. Okay, that's the one that's going to be drawing the risk on themselves. So, but it's important to note that if we do see significant changes in service provision, it will be something, especially from a national level, it will be something that we pay attention to. The last one I want to talk about, I think this is the last one, is the alignment between payment and quality. And this is sort of a weird one because we have a lot of ways in which we measure quality under the current model, okay, or under the current system. We have the SNF Quality Reporting Program, which has brought us all here for this conference. We have the SNF Value-Based Purchasing Program. We have Nursing Home Compare Star Ratings. We have all these various ways in which we measure quality. And if you just think about the definition of what value is, okay, because what we're all been driving toward, what CMS has been speaking about a lot in its messaging has been about value-driven care. If you think about what that concept means, okay, value, what it means is a balance between cost and quality. Okay, if I go to the store, okay, because I'm shopping for a new TV or a new car, I can just buy the most expensive car that's out there, the most expensive TV that's out there. Is it the best one? Maybe, maybe not. Okay, for anyone who here is really big into wine, you know that the most expensive bottle of wine is very rarely the best bottle of wine. Okay, you can get a great bottle of wine for like $10, or at least my palate does. So you want to try and balance between the two. Now, does that mean that the lowest price is the best one? No, it's what I can afford. But it doesn't mean it's the best. So what you want is a balance between cost and quality. Now, under the current system, under Rug 4, many of the existing quality metrics are in a sort of a perverse way aligned with the existing payment incentives. And one of the best examples I've seen for that is in terms of pressure ulcers. So you're not going to see a worsening pressure ulcer when you're giving everyone 720 minutes worth of therapy. If you're getting them up in the middle of the night to go take them into a therapy gym so that you can get that extra 15 minutes of therapy, they're not going to be developing pressure ulcers. So in a weird way, by chasing the incentives inherent in the payment system, you actually get the quality outcomes that you're looking for as well. Not because you're focused on the quality outcome, but because of a chasing of the payment incentive. Okay, that is where you don't see that balance between cost and quality. PDPM, however, redefines that relationship, okay, between the payment incentives on the one hand and the quality incentives on the other. So whereas under the current system, you have this overutilization incentive, okay, to provide as much therapy as possible, and as a result, sort of get the quality incentive as a bonus. Under PDPM, there's an arguable incentive to reduce the amount of therapy that's being provided. Now, if you do that, it's possible that those pressure ulcers are going to start to worsen. Okay, it's possible that instances of pain are going to increase, that rehospitalizations are going to increase. Okay, those kinds of outcomes will be the things that we monitor for. And if you chase just the payment incentive under PDPM, it is very likely that your outcomes will start to deteriorate. So what we're trying to strike is a balance between the two. Okay, again, experiment with different models of care. Reduce therapy in a way that allows the therapist to actually exercise their clinical judgment and doesn't just chase the 720 or the 500 thresholds. But ensure that you're still looking at your quality outcomes and that you're maintaining high outcomes for your patients. So all this time we've been talking about what PDPM changes. Okay, and again, it's a lot. However, one of the things that we felt it was important to talk about also is the various things that PDPM does not change. Because while we're talking about all of these changes that are being made under the SNF PPS, there's actually quite a lot that doesn't change as a result of this new model. Basic administrative processes, okay, in terms of you submit an assessment, you submit a claim that has that HIPS code, that claim gets paid, all of the sort of basic administrative processes. Okay, wage index calculations, okay, in terms of how the wage index gets applied to a per diem rate. Okay, it's about 70% of the rate that gets broken off, gets wage adjusted, and then added back to the non-labor component. Okay, QRP penalties, VBP, all of those things are exactly the same as the current system. Okay, payment associated with therapy evaluations, denial notices, NOMNICs, and ABNs, all of those are exactly the same. Okay, student supervision policy. Okay, all of these are exactly the same under the current system as they are under the prior system. There are three main areas beyond those, though, that I want to focus on as far as things that don't change. The first one being what is covered under the SNF PPS, because every single one of these we get questions about. The SNF PPS covers skilled nursing care, skilled rehab care, and a variety of other goods and services, okay, drugs and things like that. PDPM does not change in any way the coverage criteria associated with the SNF PPS. If it's covered under Rug 4, it's covered under PDPM. Okay. Now, one thing I had heard about is, well, what if someone is, only getting therapy 4 days a week or 3 days a week? That's not covered. I would argue that's wrong. Okay. That is not covered in so much as that person is only skilled for therapy, and in so much as that does not meet the daily basis requirement that we have as one of our coverage criteria. That coverage criteria doesn't change. What does change under PDPM is that it's probably more likely that you're going to be seeing patients that are skilled for multiple reasons. Okay, they won't just have the rehab-only patients. You'll have people who have nursing and therapy needs. And for those patients, they might not need 5 days of therapy a week or 720 minutes of therapy a week. They might need 3 days of therapy a week. Okay. Again, what is covered under the SNF PPS does not change one bit as a result of PDPM. The second thing that does not change is in terms of what you should be documenting. What you should be documenting is very clearly outlined in the benefit policy manual. Okay, it talks about the need for skilled involvement, that it be required to furnish those services safely and effectively, that those services be reasonable and necessary for the treatment of the individual's particular medical needs, and I think it's that individual particular medical needs that has probably been the biggest issue under the current system. Okay, all the documentation, all the things that you're required to document currently are exactly the same things you're required to document under the new system. Now, that being said, it might be that your documentation becomes more wholesome in the sense that there's a lot more that payment is riding on. Okay, it's not just on documenting their therapy and their functional score. There's a lot more, in terms of their diagnoses, their comorbidities. There's a lot more that matters to payment. And so in that sense, there may be more that you are required to document to support the payment code, but you should be documenting all those things anyway as part of good care planning. So while there's an increased relevance for certain data elements under the new system, what you are required to document in terms of the regulatory requirements doesn't change. Now, the last one is probably my favorite one, and that is that what your patient needs do not change as a result of PDPM. I'm going to give you 2 examples. If that patient needs, an important qualifier, needs 720 minutes worth of therapy as of September 30th of this year, then they need 720 minutes worth of therapy as of October 1st. If that person does not need group therapy now, if they would not benefit from group therapy as of September 30th, then miraculously they do not benefit or need group therapy as of October 1st. What a patient needs do not change just because we've changed what payment group they fall into. The whole idea behind PDPM is that what should be driving payment and thereby driving also care planning and care provision is what the patient's needs and goals are. Nothing to do with the payment system. Okay, so that is an important thing to keep in mind because the fact that we're expecting that this is going to change. We know that therapy is going to come down. We know it right now. We know that group therapy is going to go up. Okay, these are all things that we can foresee. These are all things that we're all going to be monitoring for. Okay, and it's very easy to see this in the data. Again, the data is not hard to see now. When we look at therapy minute distributions and we see those spikes at 500 and 720 minutes, okay, the data is very obvious in terms of what it shows us. It was very obvious for why it showed us that we needed to move to something like PDPM. So it'll be just as obvious when we look at the data from facility, state, national levels and see what changes as a result of PDPM in terms of care provision. Okay, so we'll be looking at things like the increased utilization of things like mechanically altered diets. Don't put your patients on a soft diet because you can get more on an SLP. Okay? Working in a facility, making some of those diets for people, they don't want them if they don't need them. So giving everyone a soft diet is just going to piss them off. Don't do that. Anomalies in comorbidity coding. If they had no comorbidities as of September 30th and suddenly they have 15, that's going to tell us something. Okay? Again, shifts in care provision and in coding between RUG4 and PDPM will draw scrutiny. Now, does that mean you're going to get a RAC review suddenly? No. Because again, all of this is counterbalanced against quality outcomes. If you maintain high quality outcomes, then we want to see you experimenting with different models of care. But what we don't want to see is those experiments being done at the detriment of the patient. All right, I'm going to step off my soapbox, move into the next topic, which is the transition from RUG4 to PDPM. Okay, because this is obviously a pretty important aspect. We talked about this in last year's final rule, that there is no transition period between RUG4 and PDPM. Okay, RUG4 ends as of date certain September 30th of this year, and PDPM begins as of date certain October 1st, okay, of this year. Okay, there's no sort of, we thought about trying to run both systems concurrently, and then that just seemed like a nightmare both for us and for you guys to try and run the 2 systems at the same time. So RUG4 will end as of September 30th, PDPM will begin as of October 1st. In order to receive a RUG4 HIPS code that can be billed for the services that you furnish prior to October 1st, you need to have an assessment that has an ARD set for on or prior to September 30th. Okay? What I mean by that is that if you have an ARD that's October 1st or after, it will not generate a RUG4 HIPS code. You'll have nothing to bill. So in order to actually get the RUG4 HIPS code, you need to have an assessment that has an ARD of September 30th or prior. Now the question that I've gotten a lot about that particular scenario is, so let's say I have a person who was admitted on September 27th, okay, or 26th or something like that. They were admitted in the last few days of September and, I don't have enough days, and this is usually the way that the question is asked. I have a patient, he's an RU patient, but I don't have enough days to get them into RU. And then I just look at befuddlement falls over me. As I say, what do you mean they're an RU patient and you don't have enough days to get an RU? You have days to give them therapy. The system will provide you with a RUG4 HIPS code. That HIPS code might actually be a nursing code because the therapy might not be sufficient for a therapy code. Does it mean you're not being reimbursed for the therapy? No. You're still being reimbursed for the therapy as of the fact that you have a RUG4 HIPS code. You might not be reimbursed for the RU code that you would have wanted if you had 5 to 7 days to get the therapy in. But we cannot change policies from RUG4 prior to September or prior to October 1st. So the RUG4 policies all still exist. You cannot short stay that person unless they meet the short stay criteria that are currently in existence. Okay. The other thing to note, okay, because we've also gotten this question a lot, is so if the ARD is set for, say, September 28th, does that mean I have to submit the assessment by October 1st? And the answer is no. You still have the same 14-day completion window, the same 14-day submission window. So you can submit it and complete it at your leisure within that 2-week period or within those distinct 2-week periods. The ARD has to be set. That's what drives the assessment. That's what drives the items that you'll see. So the ARD has to be set for on or prior to September 30th. For patients that are admitted prior to October 1st, but then continue their stay into the new fiscal year, okay, over October 1st. In order to generate the PDPM HIPS code that you would begin using as of October 1st, we are requiring that you use what is called a transitional IPA. This is the only one that's required. None of the others, they're all optional. Just this one. The ARD for that transitional IPA has to be set for one of the days between October 1st and October 7th, and payment for that transitional IPA, as opposed to a regular IPA that begins payment on the ARD, this one in particular starts on October 1st. Okay, so you'll be able to get PDPM from day one. The other thing that's important to note about this is that the variable per diem schedule, even if that person has been in the building for 30, 60, 90 days, okay, if you do the transitional IPA, you get the PDPM HIPS code. Not only does the payment begin as of October 1st, but their variable per diem schedule begins at day 1 on October 1st. Okay, so we're not going to have you calculate what day they're in their stay and then start. That was too much. If the patient's stay begins on or after October 1st, they're a PDPM person. Begin with the 5-day, payment begins as of the first day of the stay. It's the same as it would be for any other day, okay, after October 1st. Last thing I want to talk about is another topic that I'm going to say, quite frankly, I don't think that we fully appreciated the impact of, which is the effect of PDPM on Medicaid. There are a variety of ways in which the payments that we have under Medicare affect other payers. And we know that they affect things like MA and other private plans, but they also affect Medicaid. Okay? And the two main ways that they do is in terms of the upper payment limit calculations, or the UPL, and in terms of case mix determinations. The first one, the UPL calculation, okay, and we have here the definition of UPL. If you're not familiar with it, it's maximum a given state Medicaid program can pay for a given type of provider in the aggregate for Medicaid fee-for-service. It's basically the supplemental payment that's made over base payments if the base payments don't get to where what Medicare payment principles would have dictated. Now, while PDPM is budget neutral in the aggregate for Medicare payment, okay, I mentioned that $36 billion baseline. So that $36 billion stays the same whether it's drug 4 or PDPM, sorry. It can affect, however, the way that Medicaid payments are done, okay, in terms of that UPL calculation. So this is something that we have been working with states to try and help them to figure out how to do their UPL calculations. Our Center for Medicaid and CHIP Services, CMCS, is also working with states to help them to understand how this is done. And so that is something that's currently in process, that states are currently working on to try and figure out how to adapt their UPL calculations for PDPM. The second one, and one that's probably, I would argue, a little bit more complex, is in terms of Medicaid reimbursement. Those case mix states that use one of those legacy systems like RUG 3 or RUG 4 as the basis for payment. Because again, we are moving away from that. But there are states that currently don't have the data to be able to contemplate a transition to PDPM. And so the question was, what do those states do in the interim between when they can actually transition to PDPM and now? For those states, they're going to have to rely on the PPS assessments that would currently be able to produce the HIPS codes, but we're retiring a number of them. Okay, again, we're retiring the 14 through 90-day assessments, we're retiring all the OMRAs. To fill in that gap, to allow them to still collect that data, we introduced the OSA, okay, that optional state assessment. That's the assessment that states would use when they'd have a COT, or when they wanted to get some sort of interim assessment. Okay, if that's what they choose to do. States are entirely at their discretion to choose how to use the OSA to continue to use these legacy payment models. We're going to continue to support, that is, CMS is going to continue to support these legacy payment models through the OSA. Okay, we had mentioned in prior memos that came out of CMS, date certain that we would end that support. At this point, we're continuing that support until such time as we can allow the transition. We're also aware that states need things like Section GG in order to be able to contemplate a transition to PDPM, and so those are things that we're also working on to try and help states to be able to collect that data. We have a variety of resources that are available on our website. Okay, hopefully all of you have availed yourselves of them. I believe so, because a lot of you have told us about the problems in them. Thank you for that. That's always helpful. If you have questions about this, again, I think all of you have found this, the PDPM at cms.hhs.gov. Again, we're very uncreative. Email us. We will try to get a response back. If you haven't gotten a response back, I apologize. We will try to do that as quickly as possible. If you have questions related to the OSA, there's an OSA mailbox that you can also email things to. With that, I'm going to stop, but because I'm weird, I'm going to say that if any of you have any questions you'd like to ask now before we get to the Q&A, I'm going to open it up. We have about 15 minutes left. So if you guys got questions, let's fire away for a little bit.
John, do you? Here we go. Can you hear me?
Yep.
Do you foresee states having to do a quarterly assessment to meet the OBRA requirement and then potentially an OSA for the case mix component?
So the OSA and the OBRA does not in any way impact on OBRA. OBRA is not in any way impacted by anything that we're doing under PDPM. So OBRA requirements are still maintained. If you have to do an OBRA quarterly, you still have to do an OBRA quarterly. But states can choose to use the information from that quarterly for case mix purposes if they want to. No other questions. I was that clear. Or you're all introducing them to Slido.
I have a question about the Medicare certs and recerts.
Where is the question coming from?
Right here.
Oh,
As related to the interrupted stay policy,
okay.
what are the expectations around the certs and recerts?
That, again, policies related to the physician certification don't change as a result of PDPM. So where it says that it is that the physician certification is effective as of when the 5-day would be paying through, if it's an interrupted stay, that 5 days is still paying. So physician certifications are still going to maintain, again, in the same way that they do currently.
I have two questions. One is the FAQ document said that if neither the BIMS nor the staff assessment is completed, that the patient can't classify for the HIPS code.
Mm-hmm.
So what happens in that circumstance, that rare circumstance, that one of those values that you need for the CPS is dash filled?
So what it means is that you won't be able to get a HIPS code if you don't do one of the BIMS or the staff assessment. Now, there's two things I'll say. First is that I think that the scenarios in which a staff assessment would not be done has been overly interpreted based on the current manual language. That being said, we are looking to adapt the manual language to address this, but I think there are going to be more cases, like when a person unexpectedly discharges, that you could do the staff assessment. Now, there are still going to be cases in which you still can't even do a staff assessment for those people, and so you don't have a HIPS code. Okay, let's say the person comes in on day one. This was a scenario that was actually given to me by someone else, so I'm stealing her thing. Comes in on day one, is asleep pretty much the entire time the person's there, then goes back to the hospital. There's no way of doing a staff assessment, no way of doing a BIMS or anything like that. In that case, okay, one of the things to also keep in mind is that there are those Chapter 6 exceptions for when you can bill default when no assessment exists in the Keys ASAP. And one of those is when the person's stay in the building is 8 days or less. Okay, or I think it's less than 8 days. One or the other. But so in those rare cases where a person comes into the building, the person, you want to do the BIMS and you can't do a staff assessment because the person just unexpectedly discharges a few days later. Those are the cases when that Chapter 6 exception is going to come into place. Or it's going to mean that you do more staff assessments for those patients when they unexpectedly discharge. The reason that, and this is where I say it's overly interpreted, but the reason that there was language that was put into the manual that basically says that if a person could be interviewed, don't do the staff assessment. And there was a reason for that. And the reason for that, again, goes back to things like incentives. It was because the whole idea behind MDS 3.0 was to try and improve resident voice. It was to try and bring the resident more into the fold in terms of their assessment. And what we were able to see was that there were some facilities that would just dash out the BIMS and go to the staff assessment, not because the person couldn't be interviewed, but just because it was a lot more administratively easier to just do a staff assessment. That's what that was trying to avoid, was to trying to encourage facilities not to just go to the staff assessment for administrative expediency purposes. However, it has had this sort of other effect. And so that's something we're trying to address in the manual, but also, again, the Chapter 6 language, I think, addresses those rare scenarios. And that's where you would build default and you were not asleep at the wheel. So it's one of those rare cases too.
Okay, and will that be included in the grouper logic?
So no, because the grouper logic is still, if the BIMS and staff assessment are not completed, it still won't produce a HIPS code. So that's the sense in which there's still not going to be an assessment in the keys ASAP in which you can bill. So the grouper is still not going to return a HIPS code if you don't have either one. You need to have one or the other in order to get the actual HIPS code. But there are potential exceptions that will allow you to bill defaults if that rare situation occurs.
So in that case, they would not finish the assessment? What happens to that PPS 5-day?
Again, that in order to generate the HIPS code, you would need to have one of the BIMS or staff assessment completed.
Okay. And my second question is, for HIV, if somebody is in a state where they put the HIV diagnosis code in I-8000, does the grouper ignore the 8 points for the NTA
Yes.
comorbidity? Thank you.
Hey, John. Leanne Frick, over here. Hello. Hey,
Sorry,
well,
it's like blinding up here.
you mentioned the medical review,
Mm-hmm.
and you obviously referred to having certain things related to NTA, and you should be able to find that in the medical record and so on and so forth. Can you give any further insight on how the process of denials or medical review will be handled? Will it be handled by component, or any insight on that?
So I'm not sure how much detail I can give at this point. I mean, we have spoken with the various review contractors. We've spoken with our Center for Program Integrity. We've actually spoken with DOJ and OIG, I think, to kind of give them a sense of sort of how the system is changing. I think that they're still figuring out exactly what that's going to mean in terms of how they actually implement the changes in terms of their review practices. So I'm not sure I can speak to sort of denials by component and things like that. But if you think about it similar to like a re-rugging, where if a person, if they deny X number of minutes that they weren't documented, and then they put you into a different rug, I think you can probably find a similar thing here where, if, let's say you put 3 comorbidities for the NTA component, and it turns out only 2 of them are documented, then you might get a new score, and then that NTA component might be re-adjudicated. So I think that that's probably the most, I think that's probably the best I can figure out is how they would do it. Oh, sorry.
Okay. Hi. Thank you so much for this opportunity, by the way. That's
Sure.
been very helpful for the providers. My question has something to do with billing and PDPM. Will the Medicare Claims Processing Manual, Chapter 6, be updated in order to account for all the changes with the Medicare reimbursement system?
Yes, we are currently working on the changes in the claims processing manual and trying to get that out.
Prior to October 1st?
Certainly, yes. Prior to October 1st? Or prior to what first?
October.
Oh yeah, certainly prior to
yes,
October.
yes.
I thought you said like June or something.
No.
But it should be before June as well.
That would
But
be,
that's
that would be great.
that's what we're currently working on to get it out as quickly as possible. But yes, there are going to be changes throughout the claims processing manual.
One more thing, ICD coding. For the principal diagnosis code, AHIMA guidelines dictate that for the principal diagnosis code for our long-term care patients who go out, the principal diagnosis code, when they come back, will have to be the reason for continued stay. There is kind of like a contradiction or a dilemma between, I guess, what we're going to code as the principal diagnosis code, not just on the MDS, but on the claim as well, if, of course, we want to get paid for the higher RUG score, which is the reason for, the SNF care following the qualifying hospital stay. So are there any efforts in reconciling that?
Can you clarify what you're talking about reconciling? So is it the question of how to reconcile between what's coded on the claim versus what's coded on the MDS?
Right now, we're coding, AHIMA guidelines dictate
Right.
that principal diagnosis code, what we code in a claim, even if they're Med A patients, would be the reason for continued stay.
Right.
But let's say the reason for continued stay is Parkinson's, but this long-term care resident fell and had a fracture, would go out to the hospital, qualifying hospital stay, would come back. You would want, of course, that orthopedic, or if there's that fracture code, to be the principal diagnosis code and not the reason for continued stay, which is Parkinson's.
Okay, so I'll say two things, mostly because I don't want to misspeak when it comes to ICD-10. One thing I'll say is that you should absolutely be following the ICD-10 guidelines that AHIMA puts out and that exists out there. The second thing I'll say is that while I think in most cases we would expect that the diagnoses that are listed on the claim in the MDS to match, there's no edit in the system that requires them to match. Again, I don't know if that addresses your question though.
It really does not.
Okay.
Sorry. We just want to do the right thing. Now,
Right.
we're following two sets of rules, which
Well,
I think at some point,
Are you, well, hold on. Are you
we
following?
want to get paid properly. However, AHIMA guidelines are what we follow in terms of ICD coding. So
Well, okay, so I'm hearing, but, okay, so something you said, when you said we're following two sets of rules. It sounds like you're following the rule for ICD-10 coding guidelines, but then following the preference for trying to get a different payment group. Right, so that's not a rule, that's trying to attain a certain payment group. So that's where I'm not seeing inconsistency between our guidelines and AHIMA's guidelines. I'm seeing that more as a conflict between trying to maximize payment versus what AHIMA guidelines state should be coded. So I would suggest coding what AHIMA states. Although I'm guessing other people disagree from what I'm hearing to my left.
So we have time for one more question, John. I think
Okay.
Terry has someone in the back.
So I just wondered how the PDPM affects things like the sending a resident out to have like chemotherapy or something like that done. Is the facility still responsible for those types of bills? Does it affect that in any way?
So yeah, so there's no changes in terms of those kinds of basic administrative and payment policies that the facility is responsible for all of the costs that are incurred once the Medicare Part A stay begins. So if they're part of that consolidated billing, such as therapy, then they're folded into that rate, and so they would be covered in the exact same way and paid for in exactly the same way. All right, thank you all. I'll be around for questions if you have any more.